Neither the El Paso County Medical Society, its members, nor KCUS-TV shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Good evening. Cancer develops because of results of mutations in certain genes that we all have, like those involved in the regulation of cell growth and or DNA repair. What does all this mean? It's not that all mutations are inherited or that all mutations can cause cancer. We're going to talk a lot about that this evening. Scientific advances are revolutionizing the approach to genetic cancer risk, screening, prevention, and targeted therapy, all leading to very, very personalized, targeted cancer treatment these days. During this next hour, we have experts answering questions about hereditary cancer risk assessment. So what are your chances of getting cancer? Easy to ask, right? Not so easy to answer, but we're going to talk about it. Stay with us and think some questions of your own that you're going to ask this evening. This is a live show, so call us at 881-0013. This evening's program is underwritten by Texas Oncology. We know it here in El Paso as the El Paso Cancer Treatment Center, and we also want to thank the Texas Tech Paul L. Foster School of Medicine for providing the medical students who are going to be answering the phones for you this evening. And also a big thank you to the El Paso County Medical Society and all the doctors that belong for bringing the show to you each and every month. I'm Catherine Berg, and you're watching the El Paso Physician. Thanks again for joining us. Today we're going to be talking about what is my risk for getting cancer. There's all kinds of research on genetics and heredity and all kinds of stuff. 23andMe, Ancestry.com. I always call it .com, but I shouldn't. But there's a lot of tests that we can take now too that aren't necessarily done by doctors, but there's all kinds of information that we can get and or things that we think we can get that aren't necessarily what we're looking for. So with me, we have Dr. Regine Rivera, who has been with us. I don't even know how many times you've been with us. She's been with us a lot. It's not too many. Every time you come, you have fun. We always joke. Actually, we were joking about exercising and doing stairs and quads, and we're tired of that, right? We're old, but we're still young.
Yeah, but hopefully my trainers aren't watching. I love it. I do. I
do. Don't punish me tomorrow. I love it. We have Dr. Monica Diaz is with us as well. Both of you specializing oncology and hematology. And physician's assistant, we have Nydia Lopez. Thank you so much for being here. You've been here before. And this is such an interesting topic. And even though you're medical oncologist, you're physician assistant, why don't we talk about tonight, in your role here, what do you do all day, every day in the relation of what we're talking about this evening? Because I know I feel like every time we've had shows, and we've been doing this for 21 years, I've always asked you about the genetics. You're like genetic woman, you know, and you go to seminars and you learn more every year, and that, I don't know if that's your specialty, but I feel like that's always the question.
Well, it is now.
Okay.
You know, I've been a medical oncologist many years, and for the last probably 15 years have just done predominantly breast cancer.
Okay.
But breast cancer patients get other cancers and they don't want to see another oncologist. But for the last couple of years have been very interested in the cancer genetic work that the Cancer Center's doing. Managed to get our physician's assistant interested, and she is now enrolled in the City of Hope genetic cancer risk assessment course.
Very nice.
So we're really excited about it.
And it's neat too because of our medical school here, and thank you very much for coming here, Lachlan Vose here, and it's the idea of what do you go into now as a medical student. I feel like genetics is that field that is so, not that it's wide open, but there's so much more to be discovered in what's happening.
I tell people, watch the science fiction movie Galactica, I believe the name of it, where all children are tested at birth, and they give you a printout and they say by age 40 you have a 20% chance of having significant heart disease or dementia or diabetes or cancer. And you know, I think ultimately that's what we're going to do. I mean, we do it now for certain tests, right?
Right, yeah. It's a little freaky though to think. I don't know if you want to know. You know, that's,
well, but that's
do I want to know?
Well, but now remember what they said. You have a certain chance. So if you knew that you, let's say at age 50, might have a heart attack, you're a higher risk. You might watch your weight, not smoke, eat the right diet, take certain prophylactic medications to prevent that. So there are reasons behind knowing.
Yeah, the risk factors and then taking these steps. And again, early prevention. We talk about that
Absolutely.
all the time. Dr. Diaz, same thing. I just feel like I feel like I've had you on the show before, but you've not been on the show before?
I haven't been.
I think I've seen you like at Albertsons or somewhere. I feel like I know you, and it's not a pickup line. But with your being now with this beautiful team of doctors, and in the world of genetics that we're going to be talking about tonight, where do you do and what do you do all day, every day?
So I see all types of cancers right now. I'm a general medical oncologist, so I'm seeing a little bit of everything.
Nice. See a little bit of everything on that face. I was just reminded too, we are streaming live on Facebook, so if you want to ask questions via Facebook, technology, right? You were talking about.
We didn't do this.
We didn't do this 21 years ago. We didn't. So if you go to PBS, or not PBS, actually KCOS TV on Facebook, you can actually ask your questions on Facebook, as well as giving us a call at 881-0013. And again, the great thing about the show is it is live, and we're not doing anything embarrassing tonight, but when we have embarrassing shows, all of your calls are anonymous. You don't have to worry about any of that. But at least you get some answers, which is always nice. Dr. Diaz, we talked about you, Nydia. So as a physician's assistant, I feel like you see everybody. And everybody is like, oh yeah, there's Nydia. So your job all day, every day in this world is what?
Well, I support my oncologists, and I work with quite a bit of them in the office, but I'm more involved in the genetics kind of risk assessment. So we do have a clinic, Dr. Rivera, myself, and Dr. Gopalan, and we offer patients counseling, where we talk about, we take an extensive medical history, and then we offer them genetic testing if they meet the criteria for genetic testing.
And so let's start there. And I know we've talked about this for so many years now. When should someone be genetically tested for a predisposition to cancer? And I know it's a loaded question. And we've talked about in the past that those that have already been diagnosed, they're tested so that we can see if their offspring or someone in their family then has a higher chance of what you were talking about. So I feel like there's always a little bit of confusion every time we do this. So when and why would somebody be tested?
So I think the most important thing is a strong family history of cancer. And that's any cancer. It doesn't necessarily have to be one cancer. But if you have multiple family members that have, for example, breast and ovarian, and you see it in different generations, grandparents, and then your parents, and then now you're maybe the patient, that is a person that we would ideally like to get tested.
Okay. And this is even before diagnosis would be there. And I guess so let's take that answer and compare it to screenings. Because in the world of cancer, we talk about breast cancer screening, prostate cancer screening. So this is not necessarily a screening. It's when, and I think the word on here is average, someone who does not have cancer in the family, or maybe it was my great aunt, but really it's not like my direct descendant. So talk about the differences, just to make it clear to everybody at home, with screening for having your mammogram every year after 40, which I know there's controversy on that, after 40, after 50. I say after 40. But I'm not a medical doctor, I need to say that too. But screenings compared to this, how would you describe that to people?
It's not necessarily that we're screening for risk, okay? We're screening for risk. So, and one of the things I tell patients is you don't inherit cancer, you inherit risk. And so our job is to classify you as general population, familial, or a true genetic mutation carrier. And so we really want to kind of put patients in those three levels so that the clinician who's taking care of them long term knows exactly how to take care of their screening needs. Okay? Because not everybody fits, it's not a one size fit all.
Right, exactly.
Right? And so I think that That's the best answer I can give you.
No, that makes sense. That makes a lot of sense. I looked up some stuff, and this is the danger of all of us, right? We have something in our head and we want to look it up.
Absolutely.
Oh, gosh. And so actually, I usually say this at the end of the show, but we can start saying this now. When there is a question of what I have or what my mom was diagnosed or what my husband was diagnosed with, there are certain websites to go to and certain websites you don't go to. So if you can, go to a peer-reviewed site. Feel free to throw some out. The one I go to is WebMD because I use that for all things. For cancer, there's the National Cancer Institute. Right. You can just put that in the search engine, the American Cancer Society, and any others that you might want to throw out there.
What you can do? You can do some of the tertiary cancer centers. Mayo Clinic, MD Anderson have some very good websites.
Oh, of course, yeah.
Mayo Clinic in particular has had some excellent programs for certainly the more common kind of cancers. And I think that you can Google anything. Dr.
And
Google.
That's the fear, yeah, Dr. Google. And so that's why we're giving you some that would be good to Google, because there are some, too, that you just get opinions from a patient that may have had a bad day or what have you. So those are some of those areas as well. So as I was looking up Dr. Google, and this was WebMD that I went to, it was talking about all the mutations that we all have. And I think when I say back in the day, it's when we first started talking about genetic testing. I thought, oh, well, you've got a mutation, and that's why my mom got cancer, but it's not like that. And I would love to, maybe Dr. Rivera, if you could just talk about mutations, and they're not bad mutations. There's another,
Well, you know what, the geneticists are trying to get away from saying the word mutation.
It is a funny word.
And part of it is, what do we think? We
Exactly.
think of the science fiction movie from the 50s with the giant grasshoppers or, the 5 fingers on,
Exactly.
So what they're really talking about, though, are variations in genes. Now, some variations are not good things. Some variations may actually be good. So call it variations, although I know it's hard for people, they don't understand when you say a variation.
Yeah.
So I'll usually use the words interchangeably when I'm talking to patients. And I think that that's the important thing to remember. We're all different. We probably, think of a freckled, red-haired Irish person, okay? And we know that if they get lots of sun exposure, they're going to get skin cancers more than, let's say, someone who's dark-skinned. And it has to do with, of course, their skin, what they inherited, and the sun sensitivity. Is that a bad mutation? Well, not necessarily, but it does mean that they're going to need to use sunscreens. Are there, however, mutations that predispose you to skin cancers? Absolutely. More than just being a freckled, red-haired Irish person.
Right.
So.
And that's beautifully said. In this study, this is from WebMD, but it's old. It's from 2007. So we're talking, this is 11 years old. But it talked about there are passenger, and here it says mutations, but passenger variations and driver mutations or driver variations. And all 3 of you are nodding, so that's great. So let's talk about what can be an issue with the variations. You were talking about the freckles and the red hair and the blue eyes too with sunlight and all this kind of stuff. So if we're talking about passenger variations or mutations, they're just kind of along for the ride, but they don't really cause anything. Is that how we would describe it? And maybe we can talk a little bit about that. Not just what we see physically differently, but maybe there's someone in an entire family and I'll have mutations, but both of my brothers don't. And what would be passengers and what would be the driving mutations?
So I think some of the mutations that you're talking about, like the driver mutations, the ones that we look for when we do genetic testing, like BRCA mutation, the BRCA, that's a tumor suppressor gene. So what it does is it helps stabilize the DNA. So if there's a mutation in that gene, then it's not going to do that anymore. And then it'll make you more risk or a higher risk of having certain cancers that have to do with that. So that's why you have not just one kind of cancer, but you have a higher risk for multiple different kinds of cancers. So those are the ones that we're looking for.
And I know that we're talking specifically about cancers tonight, oncology, but is this also predispositions to other things, other medical issues? And Nydia, you're nodding your head. I think in cancer, that's where we've started finding out. Like someone thinks, well, my mom had a heart attack, my dad had a heart attack, my grandma had a heart attack. Okay, maybe I should take care of myself. So those are just the natural things we think of.
Families have hypertension, high cholesterol, diabetes, and I mean, look at El Paso. Look at how many diabetics we have. And families will say, I have diabetes in my family. It's probably multiple genes in that case. It's not just one. And it's also environment too. You and I both know you may have a gene that predisposes you to diabetes, but if you take care of yourself and watch your weight and eat right, you may not have the problems that your cousin has, who weighs 300 pounds and does not eat right and has high cholesterol.
And doesn't get out and
That's
exercise.
right. That's right.
It's not necessarily the trainers. It's just about getting out and walking a little bit.
I promise I'll do my exercises tonight. I promise.
Who are your trainers? We should name them and say, hey, give them a call and say, Dr. Rivera's on right now.
They're actually
You're
very
sitting
good.
down. They want you to be standing up as we're doing this interview.
Yes, I know. Squats.
Exactly. So I have some of the notes here, Dr. Rivera, that you brought in, and I love these because screening average people, but then really concentrating on the common cancers, which we have is breast, colon, and prostate. Yeah. So on that note, and Nydia, I'm going to bring this to you first because as a physician's assistant, and I know that your main job is to assist the oncologists, what questions do you get from, and let's take breast cancer patients first. What kind of questions do you get when they're asking about genetics and say this is a person whose mom did have cancer? So it's a person that's diagnosed, their mom did have cancer, but that's it. There was no aunts, no uncles, no grandparents or whatever. What are some of the questions that you get from these patients?
I think the most important question I get is, will I inherit this to my offspring?
Oh, right.
Right, and so a lot of these parents come in, now they are a patient, and they want to know what is the risk for my children. So they'll definitely concentrate on that most of the time. And then, you know, some of them come well read and they ask a lot of intelligent questions. And some of them are, I'm here because the oncologist sent me.
Oh, right.
So there's a lot of education, and I try to bring it to their level. I kind of tell them, do you know why you're here? And, you know, we just start that conversation about the reason you're here is maybe your age. You are too young to have a breast cancer.
Right.
And now your doctor wants to know if you inherited something that then we can change the trajectory of cancer in your family. And so those are the kind of things that I talk to them about.
Okay. And if that is the case, and say this person is 50, so that's still young, but this person now has kids in the 20 to 30 age range. Would it be then something, and this goes back to the original question, would you then want to test those, the 20-year-old, the 30-year-old, even though they're very young? Would you like to test them? Is that something that's encouraged, or hold off for a while? Or, because if that's one of the common questions, do my kids have this? How does that usually get handled?
Every gene is a little bit different.
Okay.
So, for example, if we use BRCA, right, which is one of the most common, we don't test children. So we always tell parents that have small children, yes, eventually your children need to be tested, but it is not an emergency, okay? And then we give them statistics, like the earliest breast cancer we have seen is in the 20s, and so we'll give recommendations as to when they have to activate that screening, that testing.
Okay. And on that line, since we're still on breast, and I'm sorry to do this to you, but let's talk about screening guidelines, not take up too much time, but as doctors, and again, there's different, you get bombarded with all kinds of, oh, so-and-so says to start screening at 40. This place says 45. This place says 50. In general, what do you tell your parents? In fact, I'll ask all three of you. Dr. Rivera, I'm just looking at you because you're right next to me.
Well, of course, you know,
and say the average, let me throw average in there.
Okay. Well,
not having any...
You know, I talk to the patient. Most people overestimate their risk. They think because their grandmother at 80 years old that had breast cancer that they're at higher risk. They might be, and you might go through an entire family history or try to figure out, you know, is this woman, does she drink a lot? Is she a smoker? Is she overweight? Does she have a high-fat diet? You know, how many relatives have had not only breast, and all of us know there's other cancers associated with this. So what if mother died of an ovarian cancer? Ooh, I'm worried about that. What if mother died of a pancreatic? What if dad had metastatic prostate cancer at 50? All of those are danger signs for BRCA.
And see,
BRCA.
that used to be just something we would say with breast cancers.
That's right. And so you have, so when you ask me, should I screen a 40-year-old? Well, if I have a 40-year-old healthy athlete who has a huge family, multiple family members, that there's no cancer, I'll discuss the pros and cons. You and I both know that a 40-year-old's going to have very dense breast, most likely, 50-50 chance, probably even higher.
Right.
And so a mammogram probably is not going to be very helpful, so she's going to have to maybe get other screening devices if she thinks she's at higher risk. But in general, you might want to delay till 45 or 50 in that patient. So it's the same thing with prostate. It's the same thing with colon. You take into consideration your patient, their personal history, how they feel now, and their family.
Right.
You can't, guidelines are exactly guidelines.
Nicely said. It's like a budget, it's a guideline.
I want to go back to one thing, because because I know you kind of asked Nydia about, so if you have a woman that comes in to see you, and let's say she has breast cancer, she's 50, and she will say, well, maybe we'll just test my children. And I'll say, no, let's test you. Because if you're negative, and I can't find anything in you, and let's say daddy doesn't have anything, why would I test your kids?
Good point.
So you always want to test the person, if you can, with the cancer. Now, you obviously can't in some instances, so remember that.
On that note, mom, who has the breast cancer, has nothing. Dad is either no longer around or, for whatever reason, can't test dad. So I know I'm throwing this out there just to confuse things.
So a negative test. So if I have a 45-year-old woman, and let's say she has 3 children. Let's say she has a daughter. Daughter is 21. Her testing comes back negative, and I say, I can't find a genetic mutation in you. That doesn't mean there may not be something, because what I do now I didn't do 5 years ago, so things are changing. So you're going to talk to me again in about 4 or 5 years, and we're going to see, are there any new things you should do? But in the meantime, your daughter is young enough, and we'll usually subtract about 5 to 10 years and start screening at that time. So if my mother had breast cancer at 45, I would probably do my screening at 35. Now we're talking, when I say screening, we're talking mammograms, MRIs, whatever. Breast self-examination, you can start, in the 20s.
Right.
One thing I'd like to get over to women, you do not, or you should try not to do mammograms under the age of 30.
And talk about that with, in that, if so, a sonogram, the dense
sonogram
breast,
or
is
an
that
MRI,
the
or an
purposing?
MRI.
Okay, or an MRI.
Now, if you live in a community that doesn't have an MRI, you do what you have to do.
Okay.
But
and the reasoning for that is it the denser
too much
breasts?
radiation.
Too much radiation.
And not it's not going to help you because of the density.
Okay.
Now, we have newer ways of doing mammograms. I know you had in October, you had the breast, and they...
Right, the 3D
and there
mammogram.
is, that's right, the 3D. A little bit more radiation with that, not a lot, but a little bit. So you have to take everything into consideration, but they're getting actually pretty good at that. And now with the computer-generated images, the radiation dose is actually pretty small.
Okay. That's always nice to hear, because not so much anymore, but I remember when we started this show over 20 years ago, that was we did the myths and truths. And one of the myths was, well, I don't want to get a mammogram because it's another x-ray that, and I had broken bones, and it really was an issue, or not an issue. It was a myth that seemed to be a big deal at the time. And I think that that's kind of gone by the wayside, because with time and more research, it's not that big of a deal. And I remember some of the myths were x-rays in the dentist office, how much radiation comes from those. And I have a lot of dental work. And so in general, I would love to, because we brought it up, put people's mind to rest that the consequences of not screening versus having a little bit of radiation, where the pros and cons are with that.
I mean, it's a very small amount. Remember, when they first started the Texas Breast Screening Project, oh, God, this was back in the 80s.
Yes, it was,
And one of the things they found is that a lot of machines are not calibrated, or were not calibrated at that time. Now, by law, you have to have a machine that is calibrated. They know exactly what kind of radiation dose they're going to get. It's nothing like, quote, the old days.
There you go. Nothing like the old days. Dr. Diaz, I would like to transition from breast to colon. And I feel like, as many of these shows that we've done, that is probably one of the most preventable cancers if you really get the screening. And we can talk first as to why, the removal of polyps, and then let's take that somewhere. Let's talk about that first, and then we'll take that into the genetics. And people may have polyps, and it could be very genetic to have polyps, but they've been benign, and then there's others genetics that they're not benign. So let's talk a little bit about polyps, why someone should get a colonoscopy, what can happen in the colonoscopy that's great, and we can take it from there.
Well, I think just to start off, colon cancer is the third most common type of cancer in both males and females. It accounts for about 8% of all cancers. This is colorectal, both together. So colonoscopies have really shown to help decrease death from colon cancer. And you want to do colonoscopies, and the screening for colorectal cancer has a few different things that you can do. Mm-hmm. So you can actually do more than just colonoscopies, and this is for the average risk person. So starting from the age of 50 to about 75, you can get either a fecal occult blood test, and if you go that route, you have to do that every year, and that's basically just checking your stool for blood. Or you could do a sigmoidoscopy, that's looking at just the distal part of the colon, and if you go that route, if you want to do that, you do that every 5 years. You can do both combined, the fecal occult blood test with the sigmoidoscopy. And then the last one is the colonoscopy that we all hear about. The colonoscopy is looking at the full colon, and if you go that route, you can do it every 10 years if things look okay. And the reason why we do the screening is because we are looking for polyps or for the cancer. Colon polyps are basically just like cells that are in the lining of the colon. Not all of them are bad, but certainly over time those can turn into cancer.
Right.
So you do want to remove them, and if you do have polyps, then that changes the screening guidelines a little bit of when the next colon cancer needs to be.
So here's the question with the fecal occult test. And if there's no bleeding, because these are polyps, say that you have polyps, if there's no bleeding, they're benign, at this point at least. I guess that's the question where it comes into, would that be an age then that do the fecal occult tests if there's some kind of issue in the family, but when you're 50 start doing colonoscopies? And the reason I'm asking that is, how can one see if there's polyps with tests that aren't endoscopies?
Right.
Does that make sense?
But
I mean,
it may be hard.
Yeah.
I mean, not everybody can afford or insurance will pay for or is willing to go through a colonoscopy. Maybe they're afraid. Maybe they've had intra-abdominal surgery. But it's not a bad way of picking up early cancer. Notice I didn't say polyps.
Right.
So it's a little bit later on, and you...
that's where risk is already passed.
Right. And these are the things that you need to talk to your patient about
Absolutely.
first. So they need to understand what their screening is and what you're looking for with those specific tests.
Okay.
Because even with the sigmoidoscopies, not all colon cancer is on the right side or the left side of the colon. Some of them can be on the left side too. So these are all things that people need to be aware of.
Okay, so that's something new to me. It's not necessarily on the right side; could be on the left side too. I didn't know that there were.
Remember, the sigmoid, the tube is only maybe that long.
It's just like a U.
Yeah.
And then it goes down to the rectum. So sometimes you can have it at the going up the colon. So that's what we call the right side of the colon, and then once it comes down the descending colon, we call that the left side.
I am embarrassed. How long have I been doing this show? And I've never looked at it in that way before. My goodness. Okay, that makes perfect sense. But I do want to get across, too, that if and when somebody is doing a colonoscopy and there are polyps and the doctor thinks, hey, that's a little bit bigger than I like, talk about what the doctor does at that point during the colonoscopy that then makes your risk go away, but
sure,
severely
they'll
decreases. Them. You're right. They'll remove them.
They'll remove them, and then they send them to pathology.
And explain how they remove them and how, the catheterization and all that good stuff.
Right. I know is that they basically sneer it, or they kind of use like
they scoop it out.
Yes, and then they just burn it, the tissue. So it's easy for them to do, and then they take it out and they send the tissue to a pathologist to look at it, make sure that there isn't any signs of cancer or early signs of cancer, and they can tell you at that time.
And the beautiful thing is that polyp is now gone.
And it's gone.
That to me is like, man, when you hear that, it's like there was a polyp there, it's now gone. So if there's may or may not grow back, but actually polyps will not grow back. I've heard that too,
It can
right?
tell you what type of polyp, too.
Oh, nicely said. And it may not be a cancer, but so let's talk about that.
And we know that some polyps are more dangerous than other polyps. So little bitty, what we call tubular adenomas, and you guys know this, we don't really think, we're not worried too much. But an adenomatous polyp, interesting. Something called a hamartomatous polyp. There are definite diseases and genetic abnormalities that are associated with that. They're rare, but you don't see hamartomatous polyps very often.
You're just showing off with that word. Say it nice and slow.
I had to practice it. And then there are a few other things. There's things called serrated polyps, and there's very rare conditions with that. So what I'm trying to say is that when people say, I've had a polyp, well, what does that mean? Villus adenomas are potentially more likely to turn into a malignancy or be a malignancy. So when a person says, I had a polyp, what do they mean? And as you alluded to, both of you, it depends upon what side of the colon. A tumor that is on the right side, that's not as common. Now, you can have a sporadic cancer, but most of the genetic, what we call the Lynch syndrome, are on the right side. Not all of them, but on that side. So if you start seeing right-sided or transverse colon, start thinking about, could this be a genetic?
Right. And that makes, again, that's new to me. So that's an interesting way of looking at it. I almost want to ask more questions about, you know what, I am, because we've got several questions here from the audience. With colorectal cancer, because I think, again, the old days, we talk about the old days. Again, we've been doing the show for 20 years, so I refer back to then. I feel like we used to call it colorectal cancer forever, and then we kind of separated the two as we were talking about them, and now I feel like we're going back to colorectal cancer again. And Dr. Diaz, you're kind of nodding your head. Is there a reason for that, or is it just me?
I think that when we talk about the risk, colon cancer is more common than rectal cancer. So when I said that 8% of all cancer that male and females have is colorectal, 70% of those are colon cancer and about 30% are rectal.
Okay.
So it's just because you screen them both the same way.
Exactly.
Too.
Okay.
So,
that makes sense. Yeah. That makes sense. All right, I've got several questions here from the audience that I want to, because we're already running out of time. We're past the half-hour mark already. So I'm going to start with this one. It's not really genetic related, but question is, and Dr. Rivera, I'm going to give this to you. Is there any hope, and that's such a powerful, scary, and good word at the same time. Is there any hope for a stage 4 breast cancer positive for estrogen? Now, they're not talking about genetics, but positive for estrogen. Hope, I always think yes. But again, I like to honor the questions from the audience. This is all we know. And so going back to the disclaimer at the beginning of the show, we can answer it or not because we don't know a lot of information
what
at
they're
all
asking
on this.
about. A stage 4 would imply a cancer that is advanced and is spread to other body organs. And
so metastatic
it's a
type. Okay.
It's a difficult question because cancers are traditionally divided into hormone receptor positive, meaning that they have certain proteins that are analyzed that are still, making these estrogen receptors. I explain it to patients. Most breast cancer comes from a milk duct or from our breast ducts. A milk duct has hormone receptors. I mean, that's what makes the breast swell during pregnancy, produce milk. Many breast cancers, over about 70%, will continue to have these hormone receptors. Now, they will make it excessively, all right, but they still will have these hormone receptors. It doesn't mean that it was caused by hormones. It just means that they continue to be sensitive or hormone. So you'll have hormone receptor positive breast cancers. You'll have hormone receptor negative cancers. And recently, within the last 10 years, we're talking about also cancers that are HER2 positive, which is a growth protein. And you can have HER2.
That's a protein.
It's a growth factor.
Gotcha. Okay.
And you can have HER2 that are both positive and negative as far as hormone. So what am I doing? I'm subdividing cancers. Cancers are not all the same, even in the same organ. And we all know this. And that's where you talk about targeted therapy. So this particular person is saying, I have stage 4 breast cancer. I'm hormone positive. And there are many options that are available to this patient. But you have to realize, where is it metastatic to? How long has she had it? How slow growing? What are her other treatments that she's had?
What's her age?
Absolutely. So there's so many things, you can't really talk about it individually, but it is true that there are many, many hormone therapies now that are available for women that have advanced metastatic hormone-positive cancer. It may not be considered curable, but we have had patients live for many, many years with one hormone-type therapy after another.
And is this treatment after the, and I'm just going to call it traditional, maybe surgery, maybe chemotherapy, maybe radiation, or is this just hormone treatment?
It depends. Was she, when she presented herself to the doctor and they made the diagnosis, did she already have metastatic disease? Or was she someone that was in remission and then had the cancer come back 1 year, 2 years, 5 years? You see, it makes a big difference.
Right.
And if it's someone that had the cancer return after many years, your treatment's going to be obviously a little bit different.
Right. Makes sense. And it is. It's always so, and that's why it's so nice to have three of you here. It's never the same answer for anyone.
Oh, absolutely.
Two people, my neighbor, my sister, even if there's twins that got cancer. They're going to be very different answers. Here is a question from the audience, and I do want to honor this because we talked about good websites, good advertising, I can't say bad advertising, misleading, I would say. So the question from the audience is this. There are new drugs advertised against cancer very often, meaning there could be like, oh, this is a preventative thing, or this is... And I've heard and see some of these too. The question from the audience is, how promising are these? And what is there to know? There was, and it says note on the bottom here, there was a new genetic drug that was released last week. I don't know anything about that. Maybe you don't either. But again, and this is where we're in the information highway.
I don't know what they mean by genetic drug. That makes no sense.
Yeah, and that's just what was on here. So and maybe they're talking about a preventative drug, a preventative drug for cancer.
And I always tell them too, if there's something that you saw online, and a lot of people sometimes forget the name or not really sure, I just say bring it in.
Right.
Let's look at it together, and then we can do our research together, because there's so many things out there that are not FDA approved or that we don't know about, but certainly we can talk about it.
Yeah. And Nydia, please.
Yeah, so a few things about that. I always remind patients, because I have patients ask me about, certain herbs. Do you think that's going to help me? Is that going to boost my immune system? And I always say you need to talk about all these things with your oncologist. Don't do it behind their back.
Right,
okay?
exactly.
And
tell everybody why, because then there's interactions.
Exactly, interactions, maybe the targeted treatment. If you use a certain vitamin or mineral, it will interact and not do its job. What I always tell patients too is we offer evidence-based medicine.
Excellent.
Okay?
Nicely said. Right.
And then they look at me like, what is that, Ms. Lopez? And I say, well, we have studied this cancer for a long time. And yes, patients have died because of, treatments or stages. And these doctors have all of this knowledge because of these studies. And they are offering you that all of those statistics that the doctors tell you, they come from there.
Exactly.
And then they go, oh, well, that makes sense. And then I remind them, a lot of these herbal supplements, there is no evidence to back them up. And so, a lot of them will ask me, well, would you try it? And I said, not if I didn't have any evidence, because I'm a scientist and I want evidence that it's going to work.
So now you are average Jolene, and you are in a, we talked about exercise, so now you're in a vitamin store, or you're just at Sprouts or Whole Foods or places that say, hey, I've got all this brand new and organic. Is there anything on a box that you're looking for? And maybe I'm going too far, but FDA approved, is that something that is safe if this is an FDA approved vitamin? What is the average person looking for when we say, okay, yeah, I know that this vitamin's good and this root is good and this tea is great, And you're looking at me like, God, don't ask that question. And
Ask them.
okay, Nidio, you get to go, and Dr. Diaz, you get to go. Because I'm in the same boat, because I think, oh my gosh, maybe I should take, I'm going to go into menopause soon, right? And so there's all these remedies that you can do and teas you can drink, and I'm just waiting for it to happen so I can go to the store and figure out what I can look at. I don't know.
You've got to take a drug for memory, for your eyesight,
Bingo!
for energy,
So I don't, yes.
so I can sleep. And pretty soon you have a little pile of pills.
Right.
And
there's
what about
aisles
the
and
drug?
aisles of all these pills.
So what I tell patients is usually there's websites that you can look these things up. Sloan and Kettering has a really good supplemental herbal.
Say that again.
Sloan and Kettering.
Sloan,
which is the cancer center.
Okay.
That's Memorial
Sloan
Memorial
Sloan and Kettering.
Okay.
So they have a really good website where you can, type in the ingredients in the supplement, and then it'll kind of give you, is there any evidence that they have seen with Western medicine to help the patient? And so, or like Dr. Diaz says, I sit down and say, well, let's do it together and see what we come up with.
Right. And that's nicely said, too. And go ahead, you were going to say because?
To add on to what Nydia said, you do want to know what's in the supplement, what ingredients is, because you want to know how they're excreted in the body, and is it going to interact with any medicine you're giving them. Sometimes if you're giving them too many things that are excreted in the liver, then the cancer that you know will work may not work as well because it's all getting excreted the same way.
Okay, you're bringing up something that's beautiful that we never talk about. The function of the liver and how it processes not only food, fine, but medications when you're talking about chemotherapy and everything that you're putting together in there. Because we've been talking a lot about fatty livers lately. It's like liver's the new rock star in things that happen in your body. I love that you started that. So when we're talking about putting several things in your body and how the liver has to deal with everything that's in there, just explain a tiny bit to the audience how two different things in one day can kind of mess you up.
Right. The liver is really what helps us break things down, and what we say metabolize is just break it down into the body so it can leave the body and it doesn't become toxic. So two ways that drugs can leave the body are either through the liver or the kidneys. Those are the main two ways. But they all have to go through the liver and help kind of be broken down. So if you're putting too many things in at once, then it's not going to work as well. So that's the main point there.
And I always want to throw in the idea of alcohol and liver. They're not friends.
Yes.
So
you can have a glass of wine, but
we talk about every now and again on our cardiac shows we talk about, well, let's put some red wine in here, but one glass is good for the evening.
You're allowed
exactly.
one.
You're allowed one.
Maybe 1.5.
Just to get you just drowsy enough to go night-night. Question here from the audience. I'm reading this cold, so my apologies. I was just diagnosed with pancreatic cancer. Can you tell me about prognosis? We can't because we don't know. How this happens, I guess we can look at this question more about risk factors. Pancreatic cancer, I feel like is
5% have been related to genetics. So most pancreatic cancers are now undergoing genetic testing. Now, it may not, and I'm just going to throw this out there, may not really help this patient, although I think that that's changing because as we know about what's the defect in the genetics, sometimes drugs are being developed that can help people with certain genetic mutations. So we'll just leave it at that for the time being. But let's say a woman has a pancreatic cancer. Let's say she's BRCA1 positive. There are potential therapies for this, but even more so, maybe you can find, it's hard to screen for pancreatic cancer, but at least maybe your family will know that you have a mutation in it, and you can screen for other cancers that might be associated with that genetic mutation. So in this day and time, most patients with pancreatic cancer, which fortunately is rare, are getting screened.
Okay. And I feel like that's one of the tough ones.
Oh, yeah.
That's one of the tough ones. Not to say anyone is again, colon, you can kind of prevent. I want to, because we're counting down on time, I want to talk about 23andMe and Ancestry, these genetic tests. And I just have them here from your notes. And who would like to have that question? Dr. Rivera? Well, Dr. Diaz is like, give him to Dr. Rivera. Well, but it's something we're all into it right now, right? It's interesting.
Fun.
Yeah.
I mean, the nurse that I work with, the RN, she did it just out of curiosity and just to find out who her ancestors were. And you can get a little idea because what they do is they have little snips of DNA that will say, oh, this is a snip of DNA, let's say from Northern Europe or Southern Europe or perhaps Africa, Asian, and so it can give you a little bit of idea where your ancestors came. They're getting better at it. I always get a kick when they say Native American. Excuse me, how many Native American tribes do we have, even in this area?
Yeah.
I mean, the Navajos are very different than the Apaches, which are very different from the Tarascans, and the southern western part of Mexico. So it's not rocket science yet, but it's fun. Now, some of these, 23andMe and Ancestry.com, what they'll do is they'll also, if you pay more money, they'll try to say, oh, well, we found some SNPs. You might be, more susceptible to diabetes or cancer. There's a couple of them that say, well, we do testing for the BRCA gene. Well, what they really do are the common Ashkenazi Jewish mutations. There's 3. That's not adequate.
Yeah.
That's not adequate.
Okay.
So I tell people they're not, you're not getting a BRCA test for $100.
Exactly.
You get what you pay for, guys. But it's fun, and it's kind of a nice thing to know. Now, I know that I have Cherokee a little bit.
Check you. That's the cheekbones. I can see it right now.
Wish. So, but I know that my nieces and nephews that have done the 23andMe, they can't find any. So if you go far enough out, it dilutes out. So we've been very interested in that. So one of these days I'll do it.
I want to do it too. We should do it together.
Okay,
it's one of those things, I talk about it all the time and then I go home or I get in front of the computer and completely forget. But I'm very curious and interested because
it's a fun thing to do.
It's a fun thing. And if you have a little bit more information, it's never a bad thing. Question here from the audience. We have a whopping 10 minutes. So I'm going to ask this because I don't know what it means and I know all 3 of you do. Question is, do you all or do you do or do people do double-blind treatments, or what is that? Is that I've never heard of that. That's why I wanted to ask it. And maybe it's double-blind tests.
Maybe they're talking about clinical trials.
Yes,
okay, well that's a good opening up to clinical trials. Then we I feel like we should just touch base on that. But then I want to go back to all 3 of you, make sure we said everything we wanted to talk about tonight. Sure. But clinical trials in the world of, I know it's not really part of genetics, but I guess that's a great question. Say that there's someone who's been diagnosed, no one in the family's ever been diagnosed, they have no idea treatment that they're taking right now isn't working. Clinical trials in general, who wants to just take that for a couple of seconds? Anyone? Dr. Diaz?
Well, just to answer that first question, I think that what double-blind means is that when you start a clinical trial, it's the way that they do it. So if they're going to be looking at a new drug and see if it works, then they don't want the physician to know or the patient to know if they're getting that drug.
I see.
Because they don't want it to have any effect on how you're documenting side effects or things like that.
Prejudice.
Okay.
Yes.
Right.
You don't want
So doctor
you don't want to have
patient.
any bias
I just know this
to
drug
it.
is going to work.
Yes, like if you really want it to work.
Right.
So they'll have like 2 pills and they might look the same and the doctor doesn't know, the patient doesn't know. So that's what double blind means.
Okay.
And so that way they have what we feel the best results.
Right.
Because
And that's what
Lydia?
we're offering. That is the evidence-based medicine we're giving.
I love
patients.
those words, evidence-based medicine.
And this person shouldn't be confused. You get treatment. You may get an established treatment, drug A, but we don't know if drug B adds anything. So you're going to get drug A, and you may or may not get drug B. So you're getting treatment. You're not getting a placebo. Right. In other words, you're getting something that is supposed to work. Believe it or not, some trials show that the drugs don't work, and I can remember about 5-6 years ago there was a trial using Avastin, which at that time was the drug. It's a blood vessel drug. It was a negative trial. And we were hoping, everybody was excited that we just knew that it was going to be the cure. It wasn't.
Yeah.
So it's important to learn, and it's very expensive, and it has a lot of side effects. It didn't work, so we don't use it.
Right. And that's where all of this comes in. And again, this show next year is going to be very different. On that note, what's different, what's on the horizon? Is there anything that we didn't talk about this evening that you'd want to get out to the audience? I'm going to start with Nydia. We've got about 8-ish minutes, más y menos, and thank you, Jimbo. He's nodding his head. I kind of, my counter downer is what he does. He helps count down. But is there something that we haven't touched base on that either patients ask you about all the time, or you just feel like we haven't touched base on and it just needs to be out there?
Well, I mean, for me, I think I see a lot of survivors. So what I usually focus on with my patients is a lot of education. Okay, now you are a survivor of a cancer. How do we prevent that another type of cancer from developing? And so, health maintenance becomes a very important topic. And they see me once or twice a year, and I'm going over that health maintenance because you're still human. You can still get a second cancer. And so I think patients, I invite patients, even if they're not affected by cancer, to come see us at the clinic to assess their risk. Okay, because you don't necessarily have to see one of us because you're a cancer patient. Maybe you have a strong family history and you just want to know a little bit about your risk. So
I'm going to be selfish. My mom died at the age of 53 of lung cancer. I'm curious. That's young. I'm 51. So should I come in and say, hey, what's going on? Should I be tested for anything? I have a very small family. My grandmother did not have any cancers, but we're from Germany. World War II took a lot of us away. So I have very little knowledge of my family history medically. So on that note,
was your mom a smoker?
My mom was, and it was small cell. So so small cell lung cancer is very much a smoker's lung cancer. So which is one of the reasons I haven't thought about that. But I'm also curious about 23andMe just to see what's out there. It's just one of those things. I would love to say that, yes, I do the show. I'm solid. I feel confident that I'm good. But there's little freak outness in every single one of us. And that's why that question gets asked.
It's all about family history.
Right.
And, we take the time to take that family history. Sometimes doctors just don't have the time. They go in, they address whatever's happening acutely and walk out. And the generalist can miss things if they're not sitting down with the patient to really take that detailed family history.
Okay. Nicely said. And sometimes, we were talking earlier, there may be a parent missing. And in my situation, I only have information on one parent.
Absolutely.
So
or
that's
adopted.
always like, or adopted, exactly.
That's right.
Exactly. Dr. Diaz, anything that you'd like to talk about before we wrap up?
I just wanted to bring home the fact that for average patients, so this is people who don't have any symptoms, may not have a lot of risk factors, but that seems to be the majority of the people out there. Screening for these major cancers, colon cancer, breast cancer, lung cancer, which is our newest screening.
That is new, and I know that's a whole nother show, but I'm excited about that.
Yes, and I can tell you a little bit about that too, but those are very important things to do. So, definitely recommendations that you should think about strongly to help prevent your risk of not just getting the cancer, but also from dying from the cancer. So lung cancer, just quickly, it is our newest recommendation. I think it rolled out in like 2011. And basically it was from a trial that was done back in 2002 or through 2009. It looked through for all the people who are at high risk for lung cancer, and they used what's called low-dose CT scans. So low-dose CT scan is basically 5 times decreased the dose of radiation than a normal CT scan is. And that trial saw that if you did that, then it decreased your risk of dying from lung cancer by about 20%.
Wow.
About a relative risk.
Okay.
So now the recommendations due to this trial is that if you are between the ages of 55 to about 75 or 80, if you are a heavy smoker, meaning at least a 30-pack year history, and are currently smoking or have smoked or have quit within the past 15 years, then they recommend that you get a low-dose CT scan once a year. Now, once you've stopped smoking for 15 years or more, then the recommendations are you can stop screening for that lung cancer. So smoking definitely is a big risk factor for lung cancer. It makes up 85% of deaths from lung cancer. So stopping or smoking cessation is the most important thing that you can do to help decrease your risk of lung cancer.
And we say stopping because back in the old days they thought it was smoking sensation. No, it's cessation. Just stop. If you can. It's not easy. There's all kinds of ways. Again, you can Dr. Google that too. How do I stop smoking? And there's a lot of good out there. Dr. Rivera, anything that we'd like to talk about before?
How much time do we have?
I was flashed the 3-minute button.
Oh,
yes.
good. No.
Yeah, I know, right?
You know, there's so many things too. I think that the one thing that I tell people is that these are actually fairly rare. The genetic, where you are born with a genetic mutation. And these are rare. There are danger signs. We've already talked about it. Multiple family members, certain types of cancer, young age, bilateral cancers like breast or even ovarian, kidney. And it's important to know your family. Now, if you don't know your family, then all you can do are average guidelines, and you do the best you can. But if you do know your family, you probably should talk to somebody if you're concerned about it. You may wind up like you did. My mom had lung cancer. Mom was a heavy smoker. Do I really need to be worried about it? You shouldn't smoke. That's the first thing somebody's going to tell you.
Right.
But you have to, you and I both know, why do some people that smoke get lung cancer and why do others not get lung cancer?
My brothers and I ask ourselves that all the time. Luckily, nobody smokes in our family. I mean, that's where we are with that. Thank you for that. We are wrapping up. I want to give a quick thank you to everybody that you don't see on the air, and we have very little time to do this, but everybody that is here. We have Jimbo, who just flashed the 1-minute sign to me. Thank you very much. Jimbo, I call him my counter downer. We have Brenda Hernandez, who's not here today, but she always has purple or blue hair, and she entertains us. We have Ralph Gonzalez, who's the teddy bear in the back. He's the gentle giant. He's doing some audio tonight. We have Richarte Gonzalez, who is the guy that has the pretty smile. He just gave me the two. If I can have you guys all over here, but I can't because you're behind the cameras. We have Liz Covarrubias, who is the quiet one behind that camera. We also have Gracie Torres, Rafa Prieto, who is Rafate, Victor, who is our intern, and then we have Leo Bentocourt, and then Mario Ramirez, who is with us all the time. He's not here tonight. Frank Luna, that's part of the team. And we also want to say a huge thank you, County Medical Society girls, Elsa Shapiro and Patsy Slaughter, and also Dr. Raj Marwa, who is on that PR committee. We've been doing this show for 21 years. I'm Catherine Berg, and you've been watching the El Paso Physician. Good night.